pleased to represent the United States Air Force, David Grant Medical Center located Travis Air Force Base in Fairfield, California. Today I'll be presenting a case of successful treatment of a difficult recurrent femoral arteriovenous fistula by utilizing a transfistula arteriovenous flossing technique. I only have two disclosures. One, if the talk goes over 5 minutes, it'll self-destruct. Two, any meaningful Super Bowl action during the presentation will be available later on ESPN. This is a 57-year-old man who presented with exertional dyspnea and left lower extremity swelling. He had a history of traumatic femoral arteriovenous fistula from a gunshot wound 15 years ago. On physical exam, he had a pulsatile mass in the left groin with a bruit, varicose veins with swelling, lipodermatosclerosis, and hyperpigmentation with palpable pedal pulses and an ABI of 1.3. On CT scan, the left external iliac vein was aneurysmal, measuring 7.9 centimeters. On duplex ultrasound, there was turbulent flow in the left common femoral vein, and a deep femoral artery to common femoral vein arteriovenous fistula was visualized. Angiography was planned. A left iliofemoral angiogram was performed, which demonstrated early venous filling at the level of the femoral bifurcation. The deep femoral artery was selected, and a 1 centimeter AV fistula was identified. Open surgical ligation was planned. A small fistulous connection between the common femoral artery and the vein was repaired, and a large fistula arising from the posterior branch of the deep femoral artery was ligated and divided. Completion intraoperative duplex ultrasound demonstrated patent arteries and veins with normal waveforms without evidence of AV fistula. On postoperative follow-up, his dyspnea had resolved, but the left lower extremity symptoms remained, along with pulsatile left groin mass with a bruit. On duplex, the femoral arteries had continuous forward flow and diastole. Further, there was high velocity continuous flow in the common femoral vein, and deep femoral artery to common femoral vein AV fistula was identified. A left iliofemoral angiogram was performed, demonstrating venous filling as before, but instead of filling early, it filled much later. Curiously, selective angiography of the left femoral artery, deep femoral artery, did not show the venous outflow as it did before. The catheter was pulled back and the angiographic field was widened to show more of the thigh. Angiography demonstrated antegrade flow of the superficial femoral artery with retrograde filling of the deep femoral artery through collaterals, which then communicated to the common femoral vein. The largest of these collaterals arose from the supreme genicular artery. Coaxial system of 5 French angle glide catheter, slim straight microcatheter, and choice extra support wire were used to gain access into the deep femoral artery in a retrograde fashion. However, the collaterals were so small that the microcatheter could not advance, meaning that there was no way to deliver the coils to the transarterial approach. Fortuitously, the wire could be advanced unsupported, and it was placed across the fistulous connection into the left external iliac vein. So to recap, from the right femoral artery retrograde access, the wire went up and over the river and through the woods and ended up in the left external iliac vein. Next, the right common femoral vein was accessed retrograde, and up and over wire access was obtained, followed by placement of 6 French destination sheath into the left external iliac vein. A tri-lobe snare was used to capture a transarterial wire, which was then externalized to the venous sheath. This created a transfistula arteriovenous flossing circuit. Over the venous end of the flossing circuit, coaxial system of 5 French burn catheter and slim microcatheter were directed into the fistula. Soft ruby coils were deployed, and completion angiography confirmed fistula closure. On post-procedural follow-up, his left lower extremity swelling had completely resolved. There was no femoral bruit, and duplex ultrasound demonstrated normal arteriovenous waveforms without evidence of fistula. In summary, this case demonstrates how multimodal diagnostic imaging can be helpful for case planning, intraoperative evaluation, and clinical follow-up of femoral arteriovenous fistulae, and in cases of difficult or recurrent lesions, transfistula arteriovenous flossing technique may be a useful approach for treatment. Mahalo, and I'd like to now open the floor for questions.
Questions from the audience? I've got one. So you're coming up and over, so when you get across with the wire, and you came up with the
Arterial or venous.
the venous one. Is it the same technique that we do to do flossing? You're just snaring it and then pulling it?
Yeah. just,
Pretty small wire thing to start with.
Yeah,
Like, what size your wire?
14 wire, we use a 14 wire the whole time.